Also good news for those who come from start
Can
now.
I just
Yes.
give any Milutin, can I just
Yes.
give an information out of the EU?
Thank you all for joining the webinar. As we wrote in the invitation, the webinar is the fourth in the series of advocacy webinars which we do in scope of the Boost project. The project which is almost at the end, just a few weeks more to end of the year and the end of the project. It was implemented in partnership between Correlation, the European Harm Reduction Network, which was the project lead, then EHRA, Euro-Asian Harm Reduction Network, Drug Policy Network Southeast Europe, and European Network of People Who Use Drugs. The main aim of the project was to develop better services for people who use drugs in cooperation with the people themselves from the communities. And the seminar will be, as I said, in two slots. It will be in two more or less parts. The first part, we will present some of the positions and documents which are related to the criminalization, and then we will hear from representatives of experts from countries which already were working or have adopted the criminalization as a model. So I just gave a short introduction, and then I invite now Igor, who is Igor Gordon from EHRA, who is the project lead in the network, who was actually coordinating the work package number 5, Connect and Act, which was actually, Igor will say more. Yes, please, Igor.
Yes, thank you, Milutin. So I just wanted briefly to tell you about the project itself and about the Boost project and about our activities. So the Boost as itself, it's a EU-funded initiative, and this project is coordinated by Correlation European Harm Reduction Network together with other regional and national partners, including DPNC, IHRA, and Your Input, and also other national partners. So our shared goal is to strengthen community-based and community-led organizations and to make them recognized and sustainable part of health systems. And the Boost project works through 4 interlinked components: inform, improve, support, and connect. So basically we collecting data, building capacity, scaling up good practices, and fostering advocacy. And so the last one, Connect and Act, is what we called Work Package 5 within this project, and IHRA is led organization. And so basically Work Package 5 focuses on strengthening and consolidating the European harm reduction networks. And basically we have 3 key aims. So first, to improve cooperation between our networks. The second is support community-based advocacy at national and local level through mentorship and small grants. And third, to translate this evidence to policy by developing different kinds of briefs and facilitating dialogue with the decision makers. And so just briefly, all our 4 regional networks, we conducted dialogue in 2023. And basically we asked what are the biggest barriers for people who use drugs in accessing harm reduction, and what works and where do we need this change. And the answers were strictly similar across all the sub-regions and different regions of the Europe. This is basically criminalization, stigma, unstable funding, and the lack of meaningful community participation. And so another important meeting was in the beginning of last year, and we gathered 22 harm reduction experts from across Europe, and we have jointly developed our advocacy strategy. And this strategy is, so we call it United for Change. It's really defined four common priorities for all our networks, what we want to advocate and work on Europe. So this is, first of all, this is political will. The second priority is promote community-driven harm reduction tailored to diverse needs of people who use drugs. Priority 3, to ensure access to specific health services for people who use drugs. And 4, ensure universal access to comprehensive health and social care for people who use drugs. And to turn these priorities into concrete advocacy, so we, all our partners develop thematic policy briefs. You can see here all 4 policy briefs. And during today's webinar, we will more focused on decriminalization, and we will discuss all the topic and discuss what we can do next in terms of them to what we can do with this issue. Also, just mentioned briefly, so we are not only working on regional level, but also on the national level, and we have supported six national organizations with small grants and with the mentorship support. So right now, all these activities already finalized, and we can now already say about the results of this project, and everything will be available on our communication channels. And this is basically it about the project. Yeah, thank you.
Thank you, Igor. I was just about to post the link, but it will be there, and I will repeat it later on. So, as Igor said, and I also, I think, mentioned a little bit that we published the advocacy brief on decriminalization. And now, okay, thank you, Igor. Now I invite Marios Atzemis, member of the board of Drug Policy Network Southeast Europe, to comment it briefly, present it, and also to include some of his personal experiences and maybe also a little bit of situation in Greece on this issue. Marios, you want me to start the presentation?
Yeah. And thank you. I would just clarify that I'm making this presentation as a board member of the Drug Policy Network of Southeast Europe. And the second clarification is that it was my first attempt to make a PowerPoint presentation with AI, and it was a complete failure. So you have to have a kind of sympathy for what you're going to see here. Dear colleagues, allies, peers, and friends, thank you for the opportunity to join to this important discussion today. My contributions focuses on why decriminalizing drug use and possession for personal use is not just an interesting policy option, but as essential and urgent step toward building societies that prioritize health, dignity, and human rights. Across Europe and globally, we have now clear and consistent evidence that criminalization of people who use drugs does not reduce use, does not reduce harm, and does not contribute to safer communities. Instead, it produces a series of unintended negative consequences, many of which are well documented by international bodies and highlighted in the Boost policy paper. Criminalization pushes people into hiding. It increases stigma, fuels marginalization, and creates real barriers to care. People fear arrest, prosecution, or surveillance, and as a result, they avoid services that could support them. At the same time, significant public resources are directed toward punishment and law enforcement, resources that could instead be invested in harm reduction, treatment, prevention, and social support. What we see very clear is this: punitive approaches undermine the very goals they claim to protect. Let's go to slide 3. This shift His understanding is also reflected at the international level at the UN GAS 2016 outcome reaffirmed that human rights, health, and development must guide global drug policy. UNAIDS has taken an especially strong position, stating unequivocally that decriminalization is a critical component of efforts to end AIDS by 2013. Their data shows that countries which criminalize people who use drugs perform significantly worse in HIV testing and treatment outcomes. The current EU drug strategy, I'm talking about the previous one, also acknowledges the need to reduce the unintended harms caused by punitive policies and highlights alternatives to coercive sanctions as a more effective and humane pathway. Let's go to slide 4. Still, the reality across Europe varies greatly. While some member states have moved toward decriminalization, others maintain criminal penalties for personal use. The results in continued human rights concerns, legal and structural obstacles to accessing harm reduction and treatment, deeply rooted stigma that deters people from seeking help, social exclusion, and policing practices that aggravate rather than alleviate risk. Criminalization contributes to poorer health outcomes, greater vulnerability, and ongoing cycles of marginalization. Let's go to slide 5. What works? Milutin? Yep. We also know what succeeds where punishment fails. Harm reduction, accessible treatment, psychosocial support, housing interventions, community-based services, and voluntary care models save lives and strengthen communities. Importantly, meaningful participation of people who use drugs, recognize them as active partners rather than a subject of control, leads to more effective and humane policies. When individuals are treated with dignity and respect, rather than fear and punishment, they are much more likely to connect with services and support. Slide 6, recommendations. Decriminalization is a crucial step, but it must be supported by broader reforms. This includes aligning laws across health, justice, social welfare, and education, adequate and stable investment in harm reduction and treatment services, training professionals across institutions from police to healthcare, public education to confront stigma and promote evidence-based understanding, embedding decriminalization explicitly within the next EU strategy. This is an important moment for Europe. The next strategic cycle offers a real opportunity for stronger alignment around health and rights. Slide 6. Let me close with this. Decriminalization is not a radical departure. It's a logical, evidence-based, human rights grounded policy direction endorsed across the UN system and demonstrated through decades of experience. It gives governments and cities the chance to redirect resources towards what works. It protects health, strengthens communities, and reduces harm. It's time for Europe and for each of our countries to take this step proactively, responsibly, and decisively. And an additional closing personal remark. From my own experience as a peer and also working closely with the community, people who use drugs, in communities, in frontline services, and in policy settings, I have seen how criminalization does far more than punish specific behaviors. It often criminalizes people's very existence. When drug use is treated as a crime, individuals are pushed further into invisibility and fear, making it extraordinarily difficult to access essential health, harm reduction, and social services. Stigma and discrimination deepen, closing off opportunities for housing, employment, education, and even basic support. And for those who do face imprisonment, the impact is devastating. People return to their community more traumatized, more marginalized, and with even fewer pathways to stability. These are not abstract consequences. They are lived realities that I witness every day. And they remind us why decriminalization is not only a policy choice, but a moral imperative. Thank you.
Thank you, Marius. Thank you for the introduction. And we have prepared now two presentations of documents which are recently published by the Eurasian Harm Reduction Network. First, Ganna Dovbakh, the executive director of EHRA, will present, and also at the same time chair of the Euro Civil Society Forum on Drugs, will present the latest updates and regional comparison for Central and Eastern Europe and Central Asia about criminalization costs. That's one of the things, one of the tools that they prepared already a couple of years ago, and now we have the latest update with the new data. Ganna, please.
Hello, everybody, and I'm very happy that we have this discussion, and very timely, specifically with this EU drug strategy and Milutin already shared, and we will all will have a couple of weeks, I guess, to absorb and to understand what we need to protest against, or maybe to develop the action plan. And I need to present the latest update on criminalization cost, and I need to say that this is not the scientific analysis, and we all understand why, because we could not calculate in very detailed data on how the criminalization cost, because that's usually aggregated data. A police action, judge work of courts, all the consequences of criminalization for people, for households, for communities could not be calculated. What we are doing here, using the community involvement and our members' involvement in the data collection and verification, we are comparing only open data, which exists for the data on cost of one person. How does it cost to keep one person imprisoned? And that's one data, one line. And the other line for comparison is the line which combine how does it cost to provide harm reduction services, which mean OST, substitution treatment, NSP, and payment for social benefits payments. And we could see that comparison is not usually very easy, because there are a lot of countries where there are no data, and sometimes there are no harm reduction already, and it means that we could not compare. That's why we are saying non-available data, because there are no harm reduction. But what we could see in the result, that the cost of keeping people in prison sometimes up to 15, 16 times, or you could see 12 times here on the smaller on the map, 12 times more than cost of harm reduction, 6 times more, 9 times more, and you could see your countries, and we all understand in the same time that all people who need to be imprisoned, who are judged to be imprisoned, they receive this payment from our taxpayer money, but not all people who need to have harm reduction could receive the harm reduction. And there are more and more countries in our region who could not receive harm reduction, and harm reduction is in the big crisis. You could for us, this data is important. Is illustration, easy illustration on of the thesis that it's much easier and much more important to pay for harm reduction and not to pay for imprisonment. And thank you, Igor, for showing what is the proper calculation, what we compared. And unfortunately, one more challenge which we saw this year, that in more and more countries we are lacking actual data on the drugs which are used, on the HIV prevalence, on the size estimation of population of people who use drugs. And that's a big challenge, because if we will see like the closing of harm reduction could have impact on the lives of people. Together with the criminalization, and a lot of countries impose more criminalization right now. Together with criminalization, it's make even more severe damage to lives of people. But statistically, governments will not see this because they don't have actual data, and they are not doing IBBS, behavioral surveillance survey, among people who use drugs. And that's the first line which is cut when we are coming to the state budget. I guess that on the next slide, Igor, could you show the next slide? Like the main trends you could see, and actually we need to say that we could not calculate it in numbers, but we see that the criminalization is increasing the financial and social burden on states, on local communities, on the budgets, and also on the lives of people and their well-being. So you saw the actual data from 2025, and that's only for Central Eastern Europe and Central Asia countries. And actually, again, I need to emphasize that the coverage by harm reduction and opioid agonist treatment in none of this country is enough. And none of our country is reaching even the minimal WHO set targets for the harm reduction coverage. And that's all what we saw in the assessment. I will be happy to answer on the questions, and we have on our webpage, in Eurasian Harm Reduction Association webpage, you could find not only updated map, and we will be happy if you will use this for your advocacy to illustrate what taxpayers are paying for, why they like to see that criminalization, it's not only ruin lives, but also cost a lot to all the society. And you will also see updated country profiles with much more data than we could illustrate on the map. I hope that you will use it as well. Thank you.
Thank you, Ganna. Very useful. I guess just to add what you said, not only that there are not enough harm reduction services, but in some countries, like we have in Bosnia and Herzegovina, there are no more harm reduction services at all. All our colleagues have closed their services, and that's probably causing more problems to the country. Okay, so since I think something like 50 years ago, there is what is called the Covenant on Economic, Social, and Cultural Rights Violations, which is being issued every year. Maria Plotko, the senior program officer from EHRA, will present the results of their document, which is actually a report on on this covenant on people who use drugs. Maria, please.
Yes, thank you, Milutin. So the report I will be talking about, it took a long time to produce it, but the data, the actual figures are not that important, but the concept of it. It was, wait a second. This report was developed as part of the process of civil society giving information for the committee to develop a general comment on the impacts of drug policies. It's actually a groundbreaking document that would help a lot in advocacy when civil society submits application, submits applications to the committee to review the states. It explains how the existing drug policy violates rights in the convention. So this report was developed by HRA together with Helsinki Foundation for Human Rights. and it was supported by Open Society Foundations. I'm sorry for the background. I have a baby there here, so you would hear some screams. So this a bit about this general comment. So it was initiated in October 2022, and then in 2023 the International Civil Society Consortium developed, and in September 2023, the committee published the annotated outline of what to expect in this comment, and kind of a guidance for civil society for what information they're looking for. And the process, unfortunately, is still ongoing. At the beginning, it was expected that by 2025, we will already have the general comment, but we still don't because it's been postponed with other general comments. But it's not forgotten. It still is happening. So the data for this report was collected through 1 offline consultation and 7 online consultations on different rights in the convention altogether in 1 specific consultation on the right to health, because as we know, we usually in our work focus on this particular right in this convention. And most of the countries from the region participated, and where the countries could not participate, they shared the data. And in addition, we had a consultant who was looking through all publicly available data, the reports submitted also to the committee, and other reports covering the violation of rights related to the convention. What makes this report unique is that, as I said, traditionally we focus on the right to health, but this publication looks at the broader picture of the rights and showing how this discrimination, criminalization, and even like employment opportunities and family policies affects the lives of people who use drugs. So on our website, you could find a regional analysis that kind of tries to give a general overview and connect it to sustainable development goals and other commitments of the states. But also there is a separate document with country profiles based on all the information collected, and there is kind of a template for reporting, which we hope would be useful for the countries when they prepare the submissions. And briefly, it's a very big report, but briefly, key findings regarding the non-discrimination is lack of anti-discrimination legislation, even where law exists. It's not usually specific to people who use drugs. There are drug registries still in several countries in the regions, meaning that people who use drugs need to register as a drug dependent, and this affects a lot of areas of their lives and access to employment and other services. And the discrimination is exacerbated for women who use drugs, and in general, other people that have some intersectional issues like sex work or belonging to LGBTQI communities. As for education and employment, there are several countries where the drug dependency is the grounds for termination of employment. There are practices when people have accumulated fines for administrative fines for drug-related convictions, and then when they go to work, all their salaries are taken from them because of that. There is also a problem of maintaining the employment because of the organization of opioid substitution treatment, and in some countries also there is a drug testing of employees. About social security and health, we all know there is an issue with access to health insurance because it often connects to being officially employed. There is inconsistent access to treatment. Sometimes it requires to have health insurance, sometimes it doesn't. It also affects people with intersectional vulnerabilities. And sometimes it's also related to having a housing, of like registered place of living. Yeah. And also is like there's mentioned the case of Belarus, but in Hungary. So there are issues when if the person is known drug user, so because of the drug registry, they might be not entitled to state support based on their other vulnerabilities because of that. So about standard of living, there are cases of termination of parental rights because of drug use. It's sometimes it's an actual law. Sometimes it's just a practice. In Uzbekistan and Tajikistan, people with HIV and drug dependence history are not allowed to adopt kids, and they have to have mandatory testing. Sorry. Before getting married. We also know that shelters for women fleeing domestic violence and also for homeless people, they usually don't accept people who use drugs or people living with HIV. So there is a lot more in this report. I think I could talk the whole hour about it, but you can read it on our website. And if you have any questions, feel free to ask us. Thank you. We worked on it longer, like we worked on it very long time. And I don't know, I was doubting who would publish first, the committee, their general comment, or we, our report, but it's finally there and you can check it out. And I hope it will be useful not only for our region, but for other countries as well to understand how the economic and social and cultural rights are violated by existing drug policy.
Thank you, Maria. Exactly what you said. It is kind of a model that the others can also use to analyze situation in their own country or region. Thank you, and oh yeah, thank you to the baby who was good most of the time. Okay, after this introduction and some general points and data, we are now going to the experts who come from 4 countries who will tell us about the history and experiences and pitfalls and challenges they had in when they were discussing or adopting decriminalization. So the first on the list is John Peter Coles, who is from the Netherlands, from Trimbos Institute in the Netherlands. But I think that most of us know John Peter as one of the senior, not senior, kind of one of the those who have been around in our area for years. So John, nice to see you again, and please do the presentation.
Thank you very much, Milutin, for your kind introduction. And thank you for the invitation. I won't have a presentation like Maria had with a beautiful small miracle on my lap, but you'll have to do it with a PowerPoint. I would like to speak on the situation of the Netherlands, and let me share my screen first. There we go. Alleen achtergrond. No. Oh, something is going wrong over here. Escape. I would like to share. Suddenly my screen looks different than before. How about this? Does this open properly?
Now it's okay. Just make it full screen.
Yeah, this is full screen. Okay. I would like to speak on the situation of the Netherlands. Most of you know the situation in the Netherlands quite well. The Netherlands has a very long history with all kinds of experiments and regulations regarding decriminalization, with some remarkable good results and some areas that we are not that successful in. And I would like to speak on that. First of all, I will speak, let's say, on the decriminalization actions in the Netherlands, deriving from the 1970s and 80s situation, and then I will have expand a bit more about the current drug situation in our country and some efforts on more regulation and decriminalization in the Netherlands. But first of all, the context of my country, the Netherlands, all of you know, is a very small country in the heart of Europe, Western Europe. It's a major transport and trade hub. We are a high-income country. We've got a social and welfare state. And in our democracy, there's a cultural strong focus on the individual rights of people and on let's say, on pragmatism. And that's also reflected, if we look how this is reflected in the drug field. For instance, the transportation hub makes us very vulnerable for transit of all kinds of. We are a transit hub for everything, from the new iPhones to methamphetamine. We are a high-income country, so we've got more resources for policies and services, and we've got a cultural of, let's say, national and local social programs in our country. Another element is that there is, like I said, there is a strong value of personal liberties, and the pragmatism is leads to, let's say, a focus on an innovation, and that's illustrated, for instance, with that dam, the picture of that dam that manages the water. It doesn't hold the water; it manages the water. So that's a bit of a background of, let's say, the situation in the Netherlands. If we look at drug policy, we are a country like any other country. We signed all the UN declarations. We follow the EU drug strategy. No, that's still the old one that you see. But the Netherlands also, based on this culture of pragmatism and innovation, we've developed a national, a more individualized response, which is more based on science and rights and pragmatism. And that's actually, that approach has elements of decriminalization and regulation in it, and it started 50 years ago. But that development has been led by several, let's say, situations in our country: the drug situation in the 1970s and the heroin epidemic in the 1980s. First, the 1970s. In 1967, there was a start of a drug policy modernization in our country. It started with a policy expert group, which decided that drugs is just a big container terminology for all kinds of different substances, and that the regulation was built on the fact that some substances were more dedicated to bring risks and harm than other substances. And that led to a national drug reform of the separation of markets. So-called hard drugs, heroin, amphetamine, cocaine, no, tutti quanti, and soft drugs, actually only cannabis. Cannabis was included in that area, and it led to a decriminalization of drug use of all substances, and a very special construction for the sale of cannabis. So, because what happened in the 1970s, there was an initial plan in the Netherlands to decriminalize cannabis from the beginning to the end. First, starting with the consumer part, that happened. That's the part of the coffee shops. And secondly, on the production and sale of cannabis. But what happened? After massive international protests, the government decided to pause after step one. So only the consumer part was regulated, and the other part was untouched. That led to a kind of a very weird almost hypocritical situation that cannabis was allowed to be sold, but was not allowed to be produced. That twisted situation is still remaining in our country, so that it led to a kind. So one part is kind of tolerated. It has the spirit of decriminalization, but in fact it's not decriminalized, but in spirit it is. Then secondly, in the 1980s, there was a heroin and HIV epidemic, and that led to a second wave of innovations on harm reductions. Also, many of you are familiar with it. That crisis led to an integrated approach with a full range of services for all people using drugs in order to protect their health. And some of those innovations were based on health promotion, and all of them started in cities and in services, so on local level. That's a very important element. And later on, they were acknowledged, endorsed, supported, and even funded by the national government. But they all started in cities and services. Over here are two newer innovations in our country. The first one is drug consumption room. Here you see that there's a kind of it started with a kind of a tolerance of illegal substances being brought in and consumed. It started at the local level, and the laws were adjusted at a later stage. The same applies for drug checking of illegally bought substances. It started as a service initiative in 1992, and it was regulated and became a national instrument in 1999. So here again, you see, it started in these innovations started in services at the local level, and they were endorsed by the government at a later level. Okay, what's the situation right now in the Netherlands? I think for over nearly 20 years, there were no major developments. Until 2017, there was a new government, and that decided to start with a committee on MDMA to assess the current situation and if medical use of MDMA could be recommended. So an MDMA commission, and the second decision of that new government was to start with an experiment to look at the controlled cannabis supply chain. So production, trade, and the consumption part, which has already been done. Okay, and on the MDMA report, the study was finalized this year, and it recommended that there are opportunities for therapeutic use of MDMA, and this will lead to clinical research, and it concluded that there are no legal adjustment can be made for recreational use as long as the criminal issues in our country, the criminal issues with production, the Netherlands and Belgium are major production areas of MDMA, as long as those criminal activities are not been solved, there will be no, according to this study, there will be no legal adjustments. On the cannabis supply chain, that started in 2017, and after 4 years of preparation, 10 cities have been selected, and production sites have been allocated. And at the moment, in 2 cities, they have started with the closed chain production, trading, and sale of, let's say, legally produced cannabis. So, and this is closely monitored and is part of an experiment. But it's actually, the real experiment has just started. The idea is that it will last for 3 more years. Right. Then There are some new developments in our country. Like in many other countries, the drug situation in our country has moved as well. And we are having big issues with drug-related crime. And actually, this led to, in the Netherlands, it led to two developments. First of all, it's a driver for more investment in law enforcement. But on a completely other side, it's also a driver for a new discussion on regulation. And over here, and one of the key promoters, advocates of this in this field is the mayor of Amsterdam, Ms. Halsema. She's a big promoter of regulating substances, not only because it's better for health, but it will also bring safer communities in the cities. And over here, you see some of the activities of the city of Amsterdam. They hosted a conference. The mayor spoke at Lisbon Addictions. They held a side event at the European Harm Reduction Conference. And currently, they are working on a blueprint for MDMA regulation in the city of Amsterdam. And they are currently exploring options for crack cocaine treatment, distribution of crack cocaine. So these are recent developments in the Netherlands. That brings me to my conclusions, actually, that decriminalization in the Netherlands, in law, it has not been realized. Actually, there's only decriminalization of the use of substances. But significant steps have been made in the, let's say, in decriminalization, for instance, with cannabis, which is formally it's not decriminalized, but it's somehow the use is tolerated and the consumption is tolerated, and this has led to major individual public health and social benefits. For instance, it resulted in the fact that generations of young people in the Netherlands grow up without a criminal record for the consumption and the use of cannabis during some period of their life. That's an enormous benefit. But security and safety issues in our country have increased and are currently not been addressed. And it also led to, let's say, the revival again of the decriminalization and regulation debates in the Netherlands. What can we learn right now? One of the things on decriminalization is that local innovations are really essential. They are very crucial. And they will have a bit more success if they are able to align with federal or national developments. And even more if there is international linkage and networking. But all of these reforms, they need continuous management and attention. And while making this presentation, I realized that actually that one of the key examples in the Netherlands of regulation is, for instance, this dam. It's 50 years old. It costs a fortune and lots of debate, but this dam, it regulates the effects of the tide. It doesn't block it. It doesn't fully leave it open, but it somehow regulates the, let's say, the forces of nature. I thought that perhaps this might be it's a nice picture and a kind of an inspiration of the direction that we're trying to move in the Netherlands. Thank you for now. And of course, I'm always open for questions, and don't hesitate to get in touch, please.
Thank you. Thank you, John Peters. I recorded two main messages. One is the tolerant approach to it, which is actually happening in many countries. And sometimes it is kind of an experimental phase of testing phase. So there is the option for that. And the other is regulation, responsible regulation, instead of what we used to call legalization before. I think it's much better to say responsible regulation than responsible regulation and legalization. Okay, thank
you.
you. Now we will give floor to Sanja Mikulic, who is the head of the Service for Combating Drugs Abuse at the Croatian Institute for Public Health. Recently, it was the Office for Combating Drugs. Now it's part of the general health approach in Croatia, which is also one of the good models that drugs are integrated in the healthcare, into universal healthcare, and not just seen as a separate document. Sanja, as I understood, I will share.
Yeah, please do it.
Yes. So that's it.
Okay. So first of all, let me thank you, Milutin, and your team for inviting us to present the experience about the decriminalization in Croatia. So let me just, can we move to the next slide, please? Okay, let me just briefly present the overview of the trends in Croatia. We have a stable trend of people in treatment for drug use disorders. Most of the persons who are in treatment are still opiate users, and among non-opiate users, mostly there are cannabis users. We notice record numbers of seizures of all type of drugs in the last 3 years, and we have a relatively stable trend of criminal offenses. Yearly, Croatian government from the state budget is spending around 120 million euros each year for the implementation of the drug policy, and half of this is related to the cost of the addiction treatment. Can we have a next slide? Also in Croatia, as Milutin just said, we have a national strategy on addiction policies from 2023, and it's integrated all kind of addictions, not only drugs, but gambling, gaming, alcohol, tobacco, and so this is also the innovation and step forward for Croatian addiction policy. In our national strategy, the strategy is based on a principle of balanced supply and demand reductions. That's the meaning of this is that there is a principle of protecting human rights, which means that there is a lot of measures and lots of focus on ensuring early intervention, enforcement of the alternative penalties, but also referring person with a drug use problem to treatment. About the treatment and harm reduction services, they are available across all sectors, health sector, social welfare, law enforcement, justice, and prison. And in the framework of the strategy, we also have a few priorities relating to the drug criminal policy, and it's focused on strengthening the health and social programs for drug-related and problematic drug use offenders, but also develop certain guidelines on cooperation between different kind of the sectors who are providing the treatment assistance to offenders. First of all, this is the healthcare sector, social welfare, and law enforcement sector, and also we are providing. We are as institute are yearly providing different kind of the trainings for the law enforcement and prison staff who are working with a person with an addiction problem. Can we move? Thank you. Related to the legal framework and decriminalization in Croatia from 2013, possession of drugs without the intention of sale in amount of the personal use has been reduced to a misdemeanor, so it's punishable by law on drugs with a fine and or treatment measures between 1 month or up to 2 years. Back then, the argumentation for the decriminalization was the EU trend to decriminalize possession. Also, the intention of the modern day criminal law not to punish the lifestyle. Also, the argumentation were that there is a need for distinguish the drug-related criminal offenders, so the production, trafficking, and offering, from the drug users. And before the legal decriminalization, also the practice was that the state attorney's office usually did not initiate criminal proceeding by making reference to the principle of opportunity, and courts usually apply the concept of insignificant offenses. So very long before the legal decriminalization, this was present in practice. Also, 2019, we saw a few amendments in the law on drugs related to the higher fines for drug misdemeanor and additional sanction, but also different kind of the treatment measures that can be ordered by the court in the misdemeanor proceeding to offender, and there is obligation of offender to comply with the treatment measures. If he or she do not complete the treatment, he will probably be charged by the fine. Or there is also possibility in the law to have imprisonment up to 3 months, but in the practice this is not implemented. Next slide, please. If we saw the trends in Croatia from 2010 till last year, we could see that after the legal decriminalization, there were a very big drop-off of the criminal offenses related to drugs. But at the same time, we noticed the increase of the misdemeanors of the drug possession for personal use. But in the last several years, this trend is also stable. Can we move on? Also, between 2014 and 2024, we could see the number of the people who were convicted for the drug-related offense are decreasing, and this trend is relatively stable through the time period. What is significant is that we also notice each year smaller number of the minors who were convicted for these drug-related offenses. Can we move? Okay. And among the people who are convicted for the drug-related offenses, the most over 61% is a suspended sentence, followed by the prison sentence, usually from 1 to 3 years, and the frequency of the prison sentence, higher prison sentence between 5 to 10 years or 10 to 15 years are relatively low, and it's not often that courts impose this kind of the year sentence. Can we move? I also have the last year that we have this data from 21st, and this is data related to drug-related misdemeanors. So people who possess drugs for the personal use, and we can see that mostly sanction is fine, but also certain number of people are referring to treatment. We would like, from the treatment and public health perspective, that there is a bigger number of the people who are paying fine for the drug possession, but also at the same time to refer them to counseling or some kind of the treatment, especially when we are talking about minors and young people. Can we move? Also, in Croatian criminal and misdemeanor legislation, we have plenty of alternative penalties, and there is plenty of intervention in the criminal justice system. For example, state attorney can suspend the prosecution for an offense which is punishable by fine or imprisonment for up to 5 years if a person go through treatment. Also, the court can impose the measure of mandatory drug addiction treatment in the health institution, but also in the NGO or therapeutic community. And also there is a possibility, we have a legal option in criminal procedure code and criminal code, so-called alternative prison sentence. So instead of the prison sentence, a court can order a person to go to the treatment in a health institution, and the time spent in the treatment is included in the prison sentence. Also, we have these legal opportunities in the misdemeanor proceeding. So a person can pay fine, but also at the same time she or he can be referred to treatment or counseling. And also there is plenty of other special obligations that can be imposed to people who commit the misdemeanor related to the drug use. Can we move? And let me conclude, because I saw in the program that I have 7 minutes, so I'm stuck with this time. So what we could see, what we can say, what are the lessons learned? We could say that for sure, initial contact with the criminal justice system is the most common first and often the only method of referring people in addiction problem to treatment. So in Croatia, rehabilitation concept has been integrated in penal system in different way. Also, introduction of the preventive treatment intervention as a support measures of a drug related law, especially in relation to young people, has proven to be justified and effective. And Croatian criminal legislation has adopted a positive approach to replacing or reducing sentence to those offenders who has drug use problems. So in Croatia from 2013 until now, we can see the effects of the decriminalization. For sure, the first one is the reduction in the number of cases in the criminal courts, because before decriminalization we have lots of cases in criminal courts which were connected with the possession of drugs for personal use. Less pressure on criminal justice and prison system. Also, more focus of the law enforcement on the complex and serious offense of drug-related crime. For sure, this is saving funds. Budget funds, and misdemeanor procedure is more flexible, is less stigmatization for the offender, and the rehabilitation process is much easier than in criminal system. So thank you for your attention.
Thank you, Sonia. I have to say that it's music for our ears from civil society when the state institutions talks about good, positive effects of decriminalization. Thank you. Okay, now I invite Joana Canedo from Portugal, who is actually a member of the Euro Input Executive Committee, to present experiences from Croatia. I have to say that Joana is a consultant working now as a PhD candidate on social movements of people who use drugs in Lisbon and in Mauritius, and that's a very good opportunity to hear something which is kind of now combination of civil society, people who use drugs, the perspective, and the university type of approach. So I will share Joana's presentation. Here we go.
Okay, hello everyone. I hope you can listen to me because sometimes my internet is a bit trouble. And if you cannot listen to me anytime, let me know and I can just shut down the video. So basically, I prepared this presentation for being here today. I think maybe most of you are a bit tired of listening up about the Portuguese drug policy model. I'm so glad, seriously, that we can find other options besides the bestseller Portuguese one. But I try to bring you some insight data from our own experience as drug users and also as a researcher. Yeah, you can proceed, Milutin, please. So basically, and most briefly, everything started back in 1999 with the National Strategy Against Drugs. This strategy was and still is very important because it addressed like the pragmatism, humanism, and also supposedly the innovation around drug policy that would proceed then with the decriminalization that might have been failed as a goal, and I will showcase why. However, this strategy was very hopeful, attributing a lot of let's say human design towards policy. So preceding this national strategy that was made by experts. So I read here something in the chat, and I guess each country has type of a think tank. There will be countries where, for instance, a doctor speaking up about decriminalization or regulation would work to kind of raise public awareness and policy interest in changing laws. There would be some other countries where lawyers advocating would have much effort. There would be other countries where church advocating for regulation or decriminalization might also be helpful. So in the case of Portugal, I think it was more on the, let's say, medical perspective of it that increased these efforts towards decriminalization. So the use and the possession for personal use became an administrative offense. So drug users were supposedly not criminals anymore. The trafficking remained criminalized. And not only criminalized, but people can still be stopped for using drugs, especially in public contexts. Okay, we did shift from a criminalization sphere to a medicalized model, but we didn't yet emancipate for a rights-based center model, let's say. I think the principal heritage that we can have to showcase in Portugal was actually harm reduction, recognized as a law in 2001. And this is actually what makes in action this decriminalization model. And I will tell you why. Can you move, please, the slides, Milutin? So basically, the decriminalization law has these commission of dissuasions of addiction that are, I have to say in disclosure that I hate this term of commission of dissuasion of addiction, and it can show from the very beginning that it's still very addiction center. So these commissions that are won by district, Portugal has 18 districts. They basically receive people who use drugs that are caught by the police, and that are referral to these commissions. And the commissions are very interdisciplinary. So they have a psychologist, a social assistant, a juridical person. And these people that arrive to the commissions, most of them are non-problematic drug users, and let's say around 90% of them. What happened, and we can see here in the graphics, it was supposed that people would be forward to the commissions of addiction, but not being still criminalized. And we can see here in this graphic that comes from an article that I recommend you to read, which is the 20 years of the Portuguese drug policy, and it's in open access, is that people are still convicted as individuals for drug use. So basically, we have two scenarios. We have the fines that don't stay in your criminal record, but they are still being troubled for many people that cannot pay them and eventually end up in prison for not paying them, okay? And we are not talking about small traffickers or traffickers. We're talking about people who use drugs. And then we have also the presence in the Commission of Dissuasion of Addiction that actually it's most engaging cannabis users. And we can also think or understand that cannabis is maybe the most seeing substance. So if anyone is smoking, it's easier to the police to arrive and pick up the substance and refer the person to the Commission of Dissuasion of Addiction. However, these people that arrive there are not having any challenging on their drug use. They actually elaborate on these theses of normalization of drug use. And I guess we need to look at the data to understand that also the commissions are maybe not so worth it to exist, as the people arriving there have not any problematic drug use or challenging drug use, on one hand. Secondly, people that might have some trouble in their drug use, some challenging experience, are already engaged in treatment centers. So no one basically arriving there is not really connected to other treatment centers in case the person needs. And thirdly, I like to highlight they still have this option of invitation to treatment, which is not actually an invitation. It's rather you go to court or you go to treatment. And this is supposed to not happen in a country that supports the human rights of people who use drugs. So next slide, please. Another thing I would like to highlight, and especially for the past years with the right-wing right-wing political sphere arriving into power, is that it became very natural to ride against people in the streets, in the neighbors, like daily. For instance, yesterday in Lisbon, 1,000 people were caught up, either using drugs or without documents, because migration and drugs are acting as like scapegoats lately a lot. And what happened, for instance, for people that really need or did a lot informally to get that drug, they stay without the drugs, and they are even going to the police station and then rather to court or again to the commissions of dissuasion of addiction. This enforcement has been concentrated specifically in public spaces and sometimes near drug consumption rooms as well. And can you please move to the next slide? So there are still tens of thousands of seizures annually. Cannabis is the majority, but the cocaine as well, and more recently more, due to Portugal is like geographically and politically located in the interest coast, let's say. And a lot of efforts have been made to tackle illicit trafficking. And I would say instead of investing in health or promoting health. The criminalization somehow persists, and this is what I wanted to highlight. The law has actually changed, and I forgot to mention that in the first slide. It's like in 2023, they did an amendment to the law, And now it's recalling on the police to understand if the person is supposedly a trafficker or if it's only a user. Before we would have these quantities. So for instance, it would be like 10 daily doses, very random doses. So it would be like 2 grams for cocaine, 1 gram for heroin, 5 grams of hashish, 25 grams of cannabis. And now it really depends on the police interaction to understand if the person is a user or trafficker, which leaves us a bit of constraints in understanding what's going on in terms of judicial processes. I can also tell you that in 2015, we had almost 10,500 processes in the Commission of Dissuasion of Addiction. And right now, that decreased for half of the number, so around 5,000 in 2024. But it doesn't mean that there were less apprehensions. So it might mean also that more cases are going into courts instead of the Commission of Dissuasion of Addiction. Can you proceed, please, Milutin? So yeah, this takes us to low drug offenses. And also it was supposed that in the law we had like this figure of a trafficker user would be a person who used drugs that do small trafficking. And according to the first strategy, the strategy from 1999, the policy of decriminalization should not be focused on these people. So these people should not be criminalized. But what we are seeing is these people are still being in judicial court scene, even for surviving dealing. And again, okay, so who gets criminalized? And I guess here we have Rui and Caso, the Portuguese Drug Users Union and Input. They did this insightful report back in 2018 on drug users' perspective inside the Portuguese decriminalization law. It can give you some insights of what I'm talking here about now. So in Portugal, the homeless population is still the most criminalized one, also because the spaces to use drugs are very rare. So we have 1 drug consumption room in Porto and 2 of them in Lisbon. And I mean, timetables are not suitable as they both close at 8 p.m. So a lot of people stay in the streets, and especially crack use as being seen as a public health threat right now, or at least a security threat, until they become aware there is also should be also a public health concern. Low-income users, women in vulnerable conditions, as harm reduction is blind to gender-based violence, no specific project shelter for women. Migrants with precarious status, and as I said, they are doing right to both drug users and the migrant population. Next. So yeah, harm reduction inside this not so good perspective that I bring you here today. Inside of this, let's say, not so innovative decriminalization model, we do have some innovative things going on harm reduction field. And this is a law that was born in 2001 and introduced it, for instance, the needle syringe programs. It created kind of authorization for drug consumption rooms. It allowed many drop-in centers to be created, and also other low threshold interventions. It was the first law to be institutionalizing to have harm reduction institutionalized in Europe, and it promotes actually the decriminalization in fact that we can see in Portugal. Next slide. Okay, we have still some challenges, and I mentioned some of them towards the criminalization of people who use drugs still, but we also have limited responses to crack, cocaine, and needle syringe, new psychoactive substances, and especially for crack, because, you know, in terms of treatment, no innovation is discussed. People strike to have access to any substitution stimulants. Well, there is no enough space also and enough paraphernalia available. And then if we have something in Lisboa and Porto, the rest of the country is a landscape, I mean, an empty landscape. Access to naloxone is still very limited. We have a chronic underfunding of harm reduction services. So the state funds like 80% of the interventions, but then like innovative interventions or things that were set up based on civil disobedience, like Gatin Moraria or Manas, which is more an advocacy-led group of women using drugs. They are not funded at all by the state. So yeah, absence of participation of civil society. There is no forum for drugs, or even regarding people use drugs, also the same and even worse, because if we still look at the let's say the policy, drug decriminalization policy has only an health issue, then the civic participation and in human rights is still far away. It's like the policy has not been emancipated from this disease model to a rights-based model. And again, so yeah, takeaways. Of course, I didn't mention, and I should, that back in time in 2001, it was very helpful to reduce HIV. So AIDS diagnosis in people injecting drugs dropped from 518 in 2000 to just 13 in 2019. And nowadays, like we look at the HIV data, and the problems are not anymore among people use drugs or inject drugs. They are actually in heteronormative middle-aged men, especially amongst the general population. The number of overdoses decreased. So in 1999, there were around 369 overdoses. And right now in 2023, we have 80 overdose. That's still a high number for a country that should that has a national health system available and should bear in mind that leave no one behind should be a priority. Stigma, we did evolve from criminals to patients, but when from patients or addicts to citizens. So the new strategy says empower, care, and protect. But I guess no harm reduction again is mentioned in the main pillars of the strategy. Even if the state, if it was someone from CICAT presenting you here, they would say, "Oh yeah, our four pillars are treatment, dissuasion, harm reduction, and reinsertion." But then again, maybe some focus go more to some efforts go more into the prevention, dissuasion, and not so much for reintegration and harm reduction. So we believe that this model has worked because actually it's a prohibitionist variant. That's why it's so much sold around the world. And there is also within this the protectionist regime that enhances dissuasion and also abolitionist prevention approach. So I guess the Netherlands has a lot of more interesting things to showcase, like drugs lab, like many drug consumption rooms that look like my dining room, and some other stuff that I pretty much enjoy. And yeah, next. And I think we are arriving to the end. There is only one more slide. Yeah, I'm just finishing. So I would like also to stress OAT patients. I mean, this thing of people being obliged to be in the line to get their methadone in specific timetables that are very framed. The fact that we never had diamorphine available to users, the investment in housing that is very reduced for people who use drugs, the lack of participation makes me say, not only me, but other researchers as well, that this decriminalization policy has operated under prohibition, and disease-focused definitions fail to empower or respect the dignity of people who use drugs. A broader health framework supports autonomy, inclusion, and human rights. And this is it from my side. Thank you.
Thank you, Joanna. It's interesting to hear. Maybe we could say it was kind of travels in a paradise, I would call it, even though Portugal is promoted as the case, I think that we are aware that there are always issues which need to be kind of adjusted. So we come to the country where there was kind of a pendulum going up and down, left and right on decriminalization to Czechia, where as far as I know, sometimes it was criminalized and sometimes decriminalized and back and forth. So we'll hear from Dr. Jana Michailidou, who is the assistant professor at the University of Chemistry and Technology in Prague and also served as the advisor to the Ministry of Justice and Addiction Policy about the current situation. Jana, please.
Okay, thank you very much. I will try to share oh my God, I will try to share the presentation. Thank you for inviting me to speak here. I will try to, okay, I'm sorry. I will try to be brief. I will, oh my God. It is telling me that I need to restart Zoom, but I will try anyway. Okay, can you see my screen?
It's okay.
Yeah, okay. I will try to be brief. I will set a timer for myself because we are already over the time allocated. So I wanted to maybe keep it optimistic. I already was introduced. And let me just start with a brief overview of how it has been in Czechia. We were one of the countries, together with Portugal and some others, that have tried to have evidence-based policy and balance of harm reduction and decriminalization. But we did not have a very straightforward path to where we are now, as you said. We strived to have harm reduction and decriminalization part of the national strategies, and since the 2019 it really has been a big part of our policies, action plans, and etc. I just wanted to have a brief mention that my work and our team's work, we are standing on the shoulders of giants. That there were many people, some of them are not with us anymore, who did the first pillars for the Czech policy as it stands now. As I said, from 2019, the Czech anti-drug policy was renamed, and now it says that it is a national strategy to prevent and reduce the harm associated with addictive behavior. So one thing that is important in the Czech strategy is that harm reduction is a central pillar of the policy, but also that we integrate addictive behaviors. So it does not only concern with drugs, but also with other addictions like behavioral addictions, etc. Where we started with our work this time around, this government turn, was that we tried to look at how we could regulate cannabis in a better way than we have it now. You can see our paper where we did a review of literature from existing regulating jurisdictions all over the world. We tried to come up with the best case scenarios that would have the best results. And also we wanted to use the window of opportunity. We had a government which is now finishing its term that had in this policy statement that we will address the issue of addiction, applying a policy based on scientifically proven and balanced approach of risk prevention and harm reduction, while ensuring sufficient funding for both prevention programs and addiction treatment services, and on regulating substances in accordance with their level of harm. I've written this statement to the policy program of the government, and let me tell you, some things came to fruition, some things not so much. But I will talk more about that. We started with 3 working groups. One working group was focusing on decriminalization. We tried to remove the paragraph on spread of toxicomania, which is a very historical paragraph which is being misused by the police. Sometimes we tried to lower the drug offense sentences. And we tried to regulate novel addiction services, which are, for example, drug checking services and drug consumption rooms, which are not, for now, allowed by law in Czechia. We also looked at assisted use of psychedelics, and we tried to introduce pilot studies with regulated access to substances. When it comes to cannabis, we tried to have these 3 pillars for the regulation. That means self-growing, cannabis social clubs, and regulated market. And there was a 3rd working group that was focusing on better regulating newly introduced substances, for example, kratom, and I will talk about that a little later. These working groups consisted of experts, civil servants, politicians, other stakeholders, for example, representatives of the institutions. Okay, so in Czech Republic, apart from the use of cannabis and other traditionally used drugs, we had a surge in use of kratom products, of low THC cannabis, of new synthetic cannabinoids. And we were posed with the dilemma if we should ban, which was, of course, preferred by the politicians because it's always the easiest case, or if we can think about some different regulation. Fortunately, we started to think about the new regulation, and the politicians listened to us, mainly because they tried the banning of the synthetic cannabinoids. For example, HHC was banned 3 years ago, but the new other synthetic cannabinoids appeared on the market maybe a few weeks from that ban. So even the politicians started saying, okay, we see the ban does not work. We need to think about something else, which was the first for us to see conservative politicians saying that bans don't work. And we ran the wave, and we tried to design a system. I will not bore you with the details about the system, but this regulation will allow, and you can read more about our new system in this article that we wrote. We thought of the system that some psychoactive substances that don't pose harms that are too severe to be allowed to be marketed to adults in licensed stores, and to not allow children to these stores, to also limit the amount of the substance in the packaging, to provide some harm reduction and prevention information on the packaging. And this is, for now, the system that we use for kratom. Regarding the decriminalization group, we really did not succeed. I'm sorry, I'm already over time. I will be quick. We didn't succeed in most of the topics that I mentioned earlier. We managed to do some lowering of the sentences for drug offenses. We did privileged paragraph for offenses regarding cannabis, and we legalized medicinal psilocybin. When it comes to cannabis, we managed to legalize self-growing and possession of a limited amount of dry herb. And as I said, we managed to pass the psychomodulatory substances bill, which was no easy task, even on the national level, and even the argumentation to the European Commission. But now we are all set, and the system is starting to work since the beginning of November. So we will see the results, and we will be closely monitoring it and evaluating the regulation. And I hope we will see good results of that we can share in a year or two. I will skip this because we all know the barriers to rational regulation. And I will just mention that it was very beneficial for us to listen to the concerns of the conservative politicians who were saying we need to protect the children. And we said, yes, we need to protect them, and we will protect them with a strict regulation, because bans and prohibition does not protect the children. And they listened to us for whatever reason it was, and we then managed to pass the legislation. Thank you. I will not take any more of your time. If you have any more questions, you can reach out to me, or you can read the articles that I mentioned. Thank you very much.
Thank you, Ganna. It's I think that each of the speakers would probably fill in twice bigger slot than they got, and I guess that most of the participants would also be happy to also contribute. We had some question from Finland in the chat, but I think that Joanna already mentioned gave kind of response. I don't know if someone would like to add something now, or we are a little bit, or where we are kind of 10 minutes already off the plan. If maybe we can give floor to Ganna, who is, as I said, chair of the Civil Society Forum on Drugs, to maybe kind of make some conclusion and tell us what are the learnings and what maybe we can turn into some actions in the forum or in the advocacy on European level.
Yes, and I'm very grateful to colleagues, and specifically to Jana and to Sanya for sharing the way you went. And actually, I think that we are, as a civil society and like-minded state representatives, we need to unite our forces to share this experience as wide as possible, because we see more propaganda of drug war in Europe, more and more. We see more and more shrinking civic space. We see more and more thinking about the police action and trafficking. And unfortunately, we all saw in the process of during 2025 that European Commission and a lot of countries have very strict plans for law enforcement action or for fighting trafficking, but we do not have harm reduction action plan. We do not have a health response action plan. And unfortunately, the EU drug strategy not mentioning decriminalization of drug use and possession as a target. And a lot of these discussions among member states and us as a civil society and political leaders, members of European Parliament, it seems like we are still fighting, like the protesting and fighting from the very underground opposition. We are still, even having the countries who already implementing decriminalization, and nothing bad happened, and only good results are shown. Having the proper indicators of the effective drug policy, we could see even more good results if we would have, and that was our demand from civil society from the very beginning of the process on the EU drug strategy development. We were asking, guys, let us discuss and agree on the specific community health and well-being indicators, measurable and clear, to see if drug policies, if fighting with the trafficking, if fighting with the supply reduction through the ports or whatever actions are, if banning if is working, let's see, because the kilogram seized, it's not an indicator of the effective drug policy. It is indicator of the frontline police officers, and we all know that this kilogram seized will be more and more and more and more and more and more anytime, because that's how the drug market is working. You are making a lot of action, but in a week or two, and we know it from our colleagues, from former police officers or actual police officers. They see on the ground and politically that you are stopping one trafficking band and line or route, and in that exact moment there will be 10 more. You are banning one substance, and in that particular moment commissions and laboratories will produce 10 substance more. So it seems like we are. It's not even the metaphor of fighting the fire which is already in the house. It is more that we are fighting with the hosts, and in the same time, budgets for harm reduction are cut. So what I feel that we really, like-minded states and us as a civil society, we need to be united to really demand from European Commission the pragmatic response to drug problems, meaning the very practical planning of and budgeting and feeding with resources the effective and cost-effective response, like harm reduction, like continuum of services from prevention to rehab. But that's something sounds so obvious, sounds so old-fashioned, but in the same time nowadays it's becoming very revolutionary. And unfortunately, we still need to fight this shit. I'm sorry for language. We still need to convince the politicians to support harm reduction, to support demand reduction, and to support pragmatic actions, and to support decriminalization. First of all, because majority of harm reduction is reducing harm from criminalization. Legal support, we're always saying, community center, legal support, safe consumption room, drug checking, everything. Majority of what we are doing, it's reducing harm from criminalization, from marginalization, from stigmatization and discrimination of people who use drugs. So we all understand this. Nothing new I said, but that's something we need to fight again, not to be tired of fighting, unfortunately, and to be united together. And I'm very grateful to states and to officials who are professional enough to understand the consequences, to plan and accurately and very wisely planning of decriminalization in country. It's also important argument for all of other neighboring countries to go the same way. I'm very happy that we have this discussion, and I'm absolutely sure that we will continue this discussion furthermore, and we need to bring more country representatives for this discussion. Behind the closed doors, okay, with the police officers to share what that you are not losing job if you are not criminalizing people. Yes, you are losing corrupted money. You are losing the bribes you are putting on every drug user you are taking in the street. But in the same time, you are not losing your job. And in the same time, you are gaining, as a policeman, as a law enforcement, you are gaining your dignity, and you are gaining your mission on working on the supporting people and supporting well-being and health of the community. So sorry for being so political and obvious, but unfortunately we will need your help fortunately or unfortunately, I wouldn't say, but honestly, we need help of academia. We need help of state officials, law enforcement, health managers, ministries of health in the countries who already tried something and have results, to show other countries that it's not dangerous and even beneficiary for the law enforcement payers and for all the taxes, for all the budgets, and for all communities.
Thank you, Ganna. Emotional, as you used to hear from you. Okay, we are already 20 minutes off. If somebody would like to say something, it can be quick, and I think I'll appreciate it. If not, I'm really thankful. I think we heard a lot, and it's really something. It's kind of it was not just kind of presentation with data and everything. There was a lot of things which were presented, but I think that we heard a lot of things which we normally don't hear on this kind of event. So I'm very happy with it. There will be a recording, hopefully soon. Those we will meet next week, holidays at the end of the year, Christmas and New Year holidays.